Hey everybody, it's Dr. Dave, Psychiatry. This is sort of fun actually. Because I got this YouTube channel, I'm able to actually show people what I do inside my office and share it with the world. The funny thing about being a psychiatrist, which as you know is a brain chemistry specialist, a medical doctor who specializes in chemistry above the neck. If you don't know that, go back and watch the previous videos. One of the things about psychiatry is that it's all very private. When someone comes in my office, the door is closed, there's nobody there but me and the patient, maybe the family. But no outsiders, there's no filming, there's no recordings. So even my own family, who has seen me gone to work every day for the last 30 years, in some ways they don't even really know what I do. So this is sort of fun because I get to share this with you and share with the world. And now my kids and my wife will be able to see exactly how I troubleshoot brain chemistry, which is what you clicked on the thumbnail for this. So today we're talking about my method for taking care of brain chemistry problems and my approach to it. Now there's the big picture here is that there's lots of things that get called mental disorders, what I call brain chemistry disorders, depression, anxiety, OCD, thought disorders, things of that nature that have official diagnoses as far as your medical insurance and official psychiatric diagnoses. But for me, the most important part is what's going on with your brain chemistry. And that's because, as I've said before, your brain is your command and control center. It controls your thoughts, your feelings, your behaviors, everything. And your chemicals in your brain, not the actual nerve cells, but the chemicals are sort of like the software. They're the parts that are vastly interchangeable. The nerve cells are like hardware. And so if you're thinking about this as a computer, you've got the structure and then you've got the chemicals. And when your chemicals go wrong, that's when you have symptoms, depression, anxiety, things of that nature. So I'm just going to sort of generally talk about troubleshooting brain chemistry through the approach, and that's going to help you as we look at other things like depression and ADD and anxiety and OCD and things that will be in other videos on this YouTube channel. If you haven't done so already, hope that you subscribe and like if you like it. The reason that's important is if you subscribe and we get a lot of subscribers, then that gets our information to the top of the search engine that helps people that might be struggling in doing searches like, what do I do for my depression or what do I do for my anxiety? And I'll say that a lot, but it's important just to support other people. You can actually help other people by subscribing. It's not, you can tell your friends and tell your family and send people to the website, to the YouTube channel. But when you subscribe, you actually give other people that need this type of help more opportunity to see it on the internet, as opposed to being buried in masses of stuff where you search, what do I do for my depression? It's hard to sort out in the University of Google, the med school of Google. It's hard to sort out what's good information. So I hope this is useful information. Let's start on just a general approach. If I've got a patient who comes to me and let's say they have a combination of depression, anxiety, panic attacks, and can't shut their mind off and they can't sleep. Let's just pick those three. The depression symptoms, which if you search on the internet, you can do a depression rating scale or see something like that, but I'll just tell you what they are. Depressed mood, the symptoms are depressed mood, low interest, not caring about things, feeling hopeless about stuff, not eating well, not sleeping well, not able to concentrate, severely diminished function, that has to be part of it. If you have those symptoms, then you're in the qualifying category for possible depression. For possible anxiety, there's lots of different anxiety disorders, but let's just talk about the big ones, panic disorder and social anxiety. And sometimes there's agoraphobia, which is fearful of, being in public places. And then the thought disorders, they can range from, I call them generalized anxiety disorders, because really if you're thinking too much, can't shut your mind off, worry too much, little things bother you, you can't let things go. A lot of times those are diagnosed different things by different doctors, but the fundamental aspect is that you're fundamentally overthinking. So once I've done an evaluation with a patient, ask my questions, and sometimes other doctors will use forms, rating scales, things of that nature. When I ask my questions in my office, if I've got a good sense that there's a possibility of depression, anxiety, and overthinking, then this is what I demonstrate and what I show to people. Once we get to the education part, this is how we start. Grab a piece of white paper and my Sharpie, and I draw two lines. This line says high, this line says low. So right now we're just talking about the normal range. We want things to be here. If I'm a diabetes doctor, I want your blood sugar to be here, not too high, not too low. If I'm a thyroid doctor, I want your thyroid hormone to be here, not too high or not too low. Same is true for brain chemistry. I want your chemicals in the middle, not outside. Now, there's no blood test or x-ray for this, which makes psychiatry in some ways a little bit harder. And if you're getting treatment from a psychiatrist or a family doctor who's writing a prescription for you for Zoloft or Prozac or Lexapro or Xanax or Ativan, they're doing their best. There's no blood test or x-ray. So this is oftentimes it's a very educated and experienced guess, but there's no blood test or x-ray for this. It's getting a sense of where the action is and then trying to do something about it. And that's where the troubleshooting comes in. So let's start with the first set of symptoms, depression. What we know about depression, what we believe about depression, is that it's probably caused by shortage of these two chemicals. One is abbreviated 5-HT, and you've probably heard of this. It's called serotonin. And the other is a naturally made chemical also called norepinephrine, abbreviated NE. And what we believe about those two chemicals is that shortage of those two chemicals, in other words, being low on those two chemicals, is what causes this thing that we call depression. We call it depression, but I'm talking about the symptoms. Depressed mood, low interest, low energy, can't concentrate, etc. So the logic is, if you're low on these two, they need to be raised to what we call the normal range. So I'm just going to put stars there to signify the normal range. And if that fixes it, say for example, we give you a medicine like Zoloft. Zoloft, the mechanism of action of all my medicines basically is really unknown, but what we do know is that people that respond to serotonin boosting medicines like Zoloft, if their depression symptoms get better, then that means that we've moved their serotonin from here to here. So that's the medical operation, getting them from here to here. And again, that's why this is a medical problem, not a mental problem, because there's no picture of mental on this. This is the medical aspect of how much serotonin is your brain actually making. What is your serotonin activity? So it starts off with, if you have a set of depression symptoms, and if we boost your serotonin with a medicine like Zoloft and you feel better, then you had a serotonin problem. Now that's the troubleshooting aspect. So if I think you're dehydrated and I make you drink a gallon of water, or just offer you to drink a gallon of water and you agree, and an hour later you feel suddenly better, you're not so tired, you're not so sluggish, your mouth isn't dry and your eyes aren't burning, then you had dehydration. You were dehydrated. And that's really the same idea here, that if you have a suspicion for an underlying condition, a lot of times a medicine like Zoloft is a test. If you don't respond to that, well, it doesn't mean that you don't have that, but it certainly does mean that if you do respond well to that, that you probably did have that problem. So that's the essence of troubleshooting. Now, let's just go to the anxiety side. What if we want to talk, what if your main problem is that you're having panic attacks, that you've been to the emergency room, maybe they told you nothing's wrong with you, and suddenly you find yourself in my office and we're talking about that type of an episode. Well, we're talking about a chemical there called GABA, G-A-B-A. We'll talk more about GABA and panic later, but what we believe is that low GABA causes panic. And the reason we believe that is that medicines that boost GABA make panic attacks better. So medicines like Xanax and Ativan and Valium, those are some of the main ones that we use to boost. They're called benzodiazepines, but I call them GABA boosters because that's what they do. They boost GABA activity. That's what they do. So if I believe that you have a problem with, if I believe your main problem is GABA, if panic and anxiety is your main problem, then I might start there and give you a GABA booster, have you back in a week or two and see what happens. And if it fixes that problem, then even though we don't have a blood test or an x-ray, that is proof enough for me that you have a GABA shortage. The third big one is dopamine. And dopamine is the one that's really misrepresented, I believe, at least in my office, on the internet, because there's all sorts of talk about dopamine rush. When you listen to good music, you get a dopamine hit and things like that. Well, that type of idea is a little bit dated. Back in the 90s and before that, dopamine was really discovered. And the truth is, dopamine is involved in motivation and interest and excitement and other things. But in my office, dopamine activity is related to thinking. The reason I say that is that when people come to me and they have major problems with overthinking, can't shut your mind off, little thing becomes a big thing, lay in bed and think and think and think. You're driving along and some guy cuts you off in traffic, and the next thing you're thinking about is how much you feel disrespected by everybody, and you end up in a road rage incident. Overthinking on the spectrum of how much you should normally be thinking is a problem for a lot of people. And the reason I believe that that's related to dopamine is that medicines that reduce dopamine activity make that better. So every day I help somebody that has a dopamine excess, and if I give them a medicine like perfenazine or Zyprexa, olanzapine, or sometimes Seroquel, quetiapine, which we use for sleep a lot. If I use medicines that push down dopamine and they feel better, that's proof enough for me that they had a dopamine problem. So the essence of troubleshooting is, number one, trying to figure out where the action is. So we're not talking about below the neck now. We're talking about above the neck chemistry. That's the medical area we're talking about. Number two is when you're troubleshooting a computer or fixing a car or something like that, you don't really want to do three things at once. If your computer is broken or your software is not running properly, you don't fix three things and run the program again. You fix one thing, change, see it, run it again, see what happens. If it fixes it, great. If it doesn't, do another thing. If it fixes it, great. If it doesn't, do another thing. And if you wiki search, if you Google search on troubleshooting, that's where that language originally developed, was troubleshooting software. So in my office, I'm troubleshooting brain chemistry. The big issue is when somebody has all three of these things, and that's where it gets more complicated. And we'll do some case studies about this later. But the big issue is, where do you start and what do you do? But I'll just give you the highlights. Typically what a patient, I ask them to do, if you're in my office, I ask you to pick where the action is. Where's the most important problem for you right now? Is it the sadness, low interest, low motivation? Is it the panic attacks? Is it the can't shut my mind off? Which do you want to fix first? Once we determine that, we do one thing. Say, for example, you pick depression. If we start with Zoloft, my time frame for seeing you back is going to be typically about a month. That's because it takes longer to work than some other medicines. If you come back and you're much better on Zoloft and your depression's better and everything else is better too, then we leave you alone. There's no need to take a second medicine. What if you picked panic attack as your number one problem? Well, then I would start with a GABA booster. And then we'd use that GABA booster. And if you came back in a couple of weeks and said, yeah, doc, we got it, we fixed it, then great, then I'm going to stay with that. Similarly, if you pick overthinking, if that's your number one problem, if you find yourself, being irritable with people or excessively angry or can't shut your mind off, can't let things go, maybe you want to start there. And if we start there and we give you a dopamine suppressor, which is what I call these dopamine suppressors. Dopamine suppressor. Because they push down dopamine activity. If I do that, then and you feel better, then that's where the action was. Now, if you come back and you're not better, then the next part of the troubleshooting is, in what way are you not better? Did the medicine make you worse? In which case, maybe we just need to try a different medicine, or do we need to try a different system? The goal is to have all the chemicals be in the middle. Whether it's one medicine, two medicines, three medicines, four medicines. And as we do case studies down the road and in separate videos here, we'll talk about how that plays out. But many people ask me, Dr. Holmes, Dr. Dave, how can you have one patient on three different medicines? Well, if I've got one medicine that's doing this, and I've got one medicine that's doing this, and I've got one medicine that's doing this, and that's what it takes to have somebody feel well, that's what I'm doing. And that's really no different than how we treat diabetes. If you have diabetes, you get three medicines typically. You get insulin receptor modulator, and something maybe for your blood lipids or cholesterol. Blood pressure, it's very common to have 2 or 3 different medicines for blood pressure, all doing 2 or 3 different things. So again, in the medical treatment of brain chemistry problems, this is no different whatsoever than what we do with other patients. The goal is to have all your chemicals be in the middle. Once you're there, there's a time frame for that. We can talk about that. But in general, what I hope people will do is stay with the medicine for at least a year once they are feeling better. And we'll talk about time duration maybe down the road with different in case studies. That is my approach to brain chemistry problems. That's what I do for a living every day. Family, friends, now you see what I do with patients every day. And it's actually quite exciting. My biggest emotion when I meet somebody who has never had any kind of treatment before is I ask them, I say, do I look excited to you? And they say, yeah, actually, doc, you do look excited. And the reason I'm excited is that once people find the chair, once people get this information, once they understand what we're doing, we now have a direction. And once we have a direction, we know we're going to help them. And that translates not just in my office, but anybody who adopts this method. If you're a nurse practitioner or a medical student or a doctor who gets exposed to lots of depression, anxiety, and you find this approach, which I was not taught, I sort of had to develop this on my own. If you and other doctors troubleshoot, don't get me wrong, I'm not the only guy that does this, but if you're not doing it this way, if you're doing the method of, hey, here's some medicine, I'll see you back in 6 months, I hope you feel better, this is a much better method. And I hope that if this helps you, that I hope that you are able to look at some of the others where we define conditions like depression, anxiety, attention deficit disorder, and make those a little more clear to you than they might be right now from the medical aspect of brain chemistry. So hope this was helpful. Thanks for being here today. I'm Dr. Dave, Psychiatry. Thanks for coming to see me.